Well, welcome everybody. It's so nice to see your faces in this room. I want to start by acknowledging the moment that we're in as a academic institution and as a place dedicated to public health, and remind our community that we have another listening session today at 4 p.m. to talk about those issues and be supportive of each other in our community. But I'm really so glad and thankful that we have something else better to focus on for the next hour of our lives, which is to hear about some really fantastic research and to lean into the things that we are all passionate about, which is improving public health. So thank you for being here as part of this Luminary lecture series. And it's my pleasure today to introduce Dr. Janet Catov, who is a professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences, as well as epidemiology and Clinical and Translational Science Institute at the University of Pittsburgh. She has extensive experience in designing and conducting studies of population and clinical cohorts to understand determinants and consequences of adverse pregnancy outcomes, such as hypertensive disorders of pregnancy, preterm birth, and gestational diabetes. She, according to Web Science, is one of the top 3 scientists globally studying the intersection of pregnancy and cardiovascular disease, an area that I know is also near and dear to many in this room and here at Emory. Her current research has focused on clues from placental function that may be markers of vascular pathophysiology that contribute to adverse pregnancy outcomes or accelerated progression of cardiovascular and cerebrovascular disease across the maternal life course and lifespan. So not only what is happening in the moment, but indeed how this sets us up for health as we go through the life course. She also leads intervention trials to improve maternal cardiovascular health during and after pregnancy, and is the director of the health and clinical research at the McGee Women's Research Institute, a member of the McGee Women's Hospital Maternal Mortality and Review Committee, and oversees the McGee Obstetric, Maternal, and Infant Database and Biobank, which is a perinatal cohort of births that are linked to biospecimens collected across pregnancy, a really valuable resource for research in the field. Importantly, she's mentored many junior faculty, postdoctoral fellows, graduate students in both medicine and in epidemiology, and in fact, just recently received the University of Pittsburgh Institute of Clinical Research and Education Distinguished Research Mentor Award, acknowledging that dedication to mentees. And I think also an important part of her career as a mentor is that nearly half of her mentees come from historically underrepresented populations. So hopefully that still doesn't give enough of a glimpse to the eminence of our luminary today, but we are once again very thankful that you're here, and I'll hand it over to you.
Well, thanks for the really lovely introduction. And, amidst this moment of, uncertainty and chaos, to come to one of the epicenters of public health is a real delight for me. So thank you so much for the gracious invitation. And I'll go ahead and get started. These are the topics I'd like to cover, although I have to be honest at the outset, I'm not really sure where we're going, but I'll give you a clue of where our own research has begun to think about in terms of what the next possible frontier might be. And I'll start with something we do know, of course, that heart disease is the leading killer of women. That remains true. This is an old slide, but I like, for a couple of reasons, I should probably update it. Many here study sex differences in cardiovascular disease. We know something about how cardiovascular disease is different in women relative to men. And I like this. These are old data from the WISE study. It's a little bit of a tribute to one of the earliest cohorts to specifically study heart disease in women. And it shows the rate of a first heart attack in women, which is the lower line, men, which is the upper line. So you see across the age span, men have heart attacks at higher rates than women. But if you look at the other axis, the case fatality rate following those first heart attacks is much higher in younger women, something that you all know and are really studying to try to understand the why. And we have hypothesized for a long time that pregnancy might offer both a real moment of vulnerability and maybe some insights about why that might be true. And these data are more recent. from a consortium of really the heavy hitter cardiovascular cohorts funded by NHLBI. On the left, these are modeling patterns of systolic blood pressure, similarly true for diastolic blood pressure. And on the left is sort of our classic, women have lower blood pressure across the life course relative to men until about age 60, something we've known for a long time. And sometimes I include data from the Framingham study back in the 60s that really say women are protected from heart disease. And I have to say, I am really humbled by that, because that came from a cohort public health study that we needed to then unlearn for the next 40 years. So we need to be, it's really humbling as epidemiologists, the way we interpret our data and the legacy of those interpretations. So these patterns of blood pressure, when modeled as rate of increase, actually tells a bit of a different story on the right-hand panel. So you can see even in the reproductive years, systolic blood pressure is increasing more rapidly in women relative to men. So I was talking with several great colleagues in my time here so far at Emory, and I learned more than 20 years ago as a doctoral student that we need to sort of stratify our data by sex and race to actually reveal differences, something that is emerging as potentially under threat, but we've known as epidemiologists for a long time that unless we stratify our data, we actually don't even have the chance to understand differences, let alone to study them. And then this is really a really pivotal piece in my work, published more than 20 years ago. There are now so many studies showing that pregnancy complications are markers of women at accelerated risk for progression to cardiovascular disease and death. These are survival curves. And the red line at the top is sort of our age, expected age reduction in survival relative to women with uncomplicated pregnancies. This lower, most severe diminished survival is for women who have preterm preeclampsia, early onset, more severe hypertensive disorder of pregnancy. And much of my work started by trying to understand this blue line of women with normotensive preterm births also are at accelerated risk for cardiovascular disease for reasons that we at that time really did not understand. I came into this world when preterm birth was thought to be infectious related or certainly inflammatory related. I think we now understand that about a third of preterm births have a vascular pathophysiology, and that's a group that we've studied for a long time. And updated, so those data are from a time ago. This is a really recent one of many, many review papers that now has kind of assembled the body of evidence linking a variety of adverse pregnancy outcomes. In the OB world where I live, many of these are thought to be the great obstetric syndromes that are known to be detrimental to maternal health and dangerous for infant health as well. Preeclampsia and gestational hypertension, as well as gestational diabetes, preterm birth, and delivery of a small baby. So there's abundant evidence now that all of these are markers of elevated risk for cardiovascular disease in women. And these data are another way to look at this, published by Malamo Contouras, one of the cardiologists I work with at Pittsburgh, who looked at premature MI, which she defined as a heart attack before age 65 in women, and showed that women with preeclampsia present with a first heart attack years earlier than those with uncomplicated pregnancies. And again, this is among a cohort, all of whom had heart attacks before age 65. So again, this is like looking at a high-risk group and now disaggregating those groups by their pregnancy history, and that we could see earlier presentation of that first heart attack in those with gestational diabetes and really any adverse pregnancy outcome. So these data continue to accrue so we can begin to disentangle the why behind that, so we might have a chance to actually change that trajectory. And then these data are data we are still just recently analyzing from the Heart Health Study, which is a consortium funded by, initially funded by NICHD, which was a cohort of 10,000 women enrolled at 7 clinical sites across the country of first pregnancies. So really unique, not looking at any pregnancy, but very intentionally looking at first pregnancies. And the NICHD study was to understand determinants of adverse pregnancy outcomes. And then NHLBI has carried that cohort forward. And now about 4,500 of those women are studied every 5 years for the emergence of cardiovascular disease. So we looked at not just the occurrence of an adverse pregnancy outcome in a first pregnancy, where a lot of this cohort has so far been focused, but what about if we begin to look at cumulative birth history? Because we know, again, I live in an OB world. I'm an epidemiologist living predominantly in an OB world. And it really dawns on me that we study pregnancy like a cross-sectional event. Women come in, they go out. You know, they have a healthy outcome or a complicated outcome. But we know that women enter pregnancy with the sort of accrual of what they bring into pregnancy, and then subsequent births also may contribute to that accrual of risk. So this is actually just categorizing the occurrence of elevated blood pressure by 5 to 7 years after a first pregnancy. So very early in the life course. These women were average age about 29 at a first pregnancy. And by the time we're studying them for the emergence of high blood pressure, they're, like 32 years old. So these first 2 bars show the distribution of normotensive, elevated blood pressure, stage 1 and stage 2 hypertension, according to their adverse pregnancy outcome occurrence in the first 2 pregnancies. So no APOs in either birth, which you can see is the sort of the healthiest blood pressure profile, but pretty similar to those who had no APO during the first pregnancy, and they did not yet have a second pregnancy by 5 to 7 years. So they are somewhat similarly risked for high blood pressure. The second 2 bars show those who had an APO in a first pregnancy only, or those who had an APO in a second pregnancy only. And those also have, somewhat higher risk for elevated blood pressure relative to those who had uncomplicated pregnancies. And interesting to my OB colleagues, they don't really think about de novo APOs in a second pregnancy, but not in a first. It does happen, and our group's been trying to understand. I'll share some of those data with you as well. And then what we hypothesized would be the group at highest risk for elevated blood pressure would be those who had an adverse pregnancy outcome in both pregnancies, the first and the second. But it turns out that the other high-risk group are those who had an adverse pregnancy outcome in the first pregnancy and did not yet or may never have a second pregnancy. And there are some data out of the Scandinavian cohorts that the group that has only 1 pregnancy that is complicated is actually perhaps the biggest driver of this accrual of risk across the life course. And it really speaks to us as epidemiologists who understand the importance of the entire life course, but that we really can't just study 1 pregnancy in order to actually understand this sort of life course accrual of progression to accelerated cardiovascular disease. So these are early days. We're looking at a very basic risk factor of high blood pressure, but I'm hopeful that the cohort will continue and will better understand mechanisms. Go ahead, Tanay. No second birth. Great point. We are now disentangling short pregnancies. So in order to be in this cohort, initially, you couldn't have more than 2 miscarriages. And we are now just analyzing the short pregnancies, spontaneous abortions, et cetera. We suspect that there could be a component of subfertility, that maybe losses are contributing. I was having a great conversation with Kate Stanhope about, we know that those who have a really complicated first pregnancy, they may not actually even want a second pregnancy, right? So there's, you all are probably at the forefront of understanding how stress contributes to this story. And there is so much more work to be done, but it's a great point about losses, because we know that multiple miscarriages are also markers of cardiovascular disease. And my hypothesis would be the accrual of these adverse outcomes, whether they're short pregnancies, complicated pregnancies, other reproductive kind of health complications, likely contribute to this as well. Great point. So what I'll look to turn now to kind of where we've done a lot of work thinking about perhaps there is a common vascular phenotype underlying these adverse pregnancy outcomes. And we asked a really simple question. What if we looked at the placenta? So we know that women with preeclampsia are more likely to have evidence of vascular abnormalities in the placenta. But it turns out that other adverse pregnancy outcomes are also associated with those vascular lesions. This paper by Abby Lane Cordova is a really nice articulation of that women likely, this is hypothesized, women may enter pregnancy with modestly elevated risk factors, that then the stress of pregnancy actually stresses the biology that is, and the result might be poor placentation. And she's listed some of the most classic vascular placental abnormalities that are then associated with an adverse pregnancy outcome. Those women progress to sort of subclinical abnormalities and then to overt cardiovascular disease. We've also begun to think about the heart-brain axis, and I'll share with you some of our work looking at maternal brain as well. And then I like her inclusion here of, this is not a fait accompli. We know there are certain aspects, certain lifestyle aspects. Stress is one, physical activity is another, sedentary behavior, that there could be other factors that exacerbate this profile or may mitigate this risk profile, something that's important to consider as well. And very briefly, this is just my one slide to teach just a tiny bit about placentation. The cartoon on the left shows all the way on the left are these really tightly coiled, very small spiral arteries that perfuse the uterus. Then all on the right of that cartoon is this really rather profound remodeling of those spiral arteries by the fetal trophoblast that actually completely eliminates the muscular layer of those vessels. So they become these widely dilated, highly perfused vessels that feed blood to the maternal fetal interface. And then in the middle is this cartoon of what happens in this cartoon is calling it ischemic placental disease, sort of failed spiral artery remodeling, where there is some remodeling, but it's incomplete, resulting in a sort of a poorly perfused placenta. The slide, the image on the right here shows what this looks like on a histology slide. This is kind of an example of the most specific and chronic of these vascular lesions, vasculopathy, where there is also what's called acute atherosis, because it has a lot of similarities to an atherosclerotic lesion, where the vessel wall has these lipid-laden macrophages. They stain dark pink. They become very rigid with fibrosis. We see that in the placenta. We also see downstream hypoxic injury in the parenchyma of the placenta as well, all upon histology review that get classified as these maternal vascular malperfusion lesions. And then our hypothesis was really very simple. Do injuries like this on the maternal side of the placenta might they be precursors of a similar microvascular injuries in maternal, in the systemic vasculature, in the heart, and maybe even in the brain? So we looked at the placenta, we said, could it actually help identify severity of the pregnancy phenotype? What about future pregnancy risk? We had keen interest in understanding the emergence of maternal cardiovascular disease, and as I said, maternal brain health. And this is just sort of how we built this cohort at our hospital. So in this registry of births at our hospital, which we fondly call MOMMY, the McGee Obstetric, Maternal, and Infant Database, during this 5-year time period from 2008 to 2012, we had about 50,000 births, and a little bit under half of them actually had a placental evaluation. We have a pretty big perinatal pathology group. And then we took all of those pathology reports, deployed natural language processing to abstract them, and ended up with a cohort of about 21,000 births with placental evaluations. And we've done work with that clinical cohort, and we also enrolled almost 500 of those women to study more intensively for the emergence of cardiovascular disease. These are some of the early papers we published. Vanessa Asibi-Mensah is a great postdoc working with our group, demonstrated that Black women relative to white women were about 60% more likely to have the most chronic and specific of these vascular lesions, the vasculopathy that I shared with you. Tony Parks, who's the perinatal pathologist who I've done all of this work with, has demonstrated that increasing severity of pre-pregnancy obesity was also associated with a higher risk for vasculopathy. And then Jackie Atlas, as a resident, now a maternal fetal medicine fellow at McGee, did this really clever study where she went back in the medical record and identified women who had and did not have these vascular lesions in the placenta, and then looked up to 3 years pre-pregnancy to see, was there a routine clinical visit where blood pressure was measured? And was there a difference in the pre-pregnancy blood pressure that might have predisposed women to these lesions? And then looked at the first blood pressure measured in pregnancy. And in this small cohort of about 100 women, there wasn't a difference in the pre-pregnancy blood pressure by the occurrence of these lesions or in the early pregnancy blood pressure, but the delta between pre-pregnancy and early pregnancy was blunted, such that we have known for a long time that there is this rather profound drop in blood pressure in the first 20 weeks of pregnancy. All of the entire maternal vasculature, I showed you the profound remodeling at the level of the uterus, but across the systemic vasculature, there is a reduction in resistance that leads to lower blood pressure that naters at about week 20 and then returns in a normal pregnancy to baseline pre-pregnancy by late gestation and stays normal. What Jackie showed was that those who had these lesions in the placenta had a blunted systolic, but particularly diastolic blood pressure between pre-pregnancy measured blood pressure and that first blood pressure measured early in pregnancy, suggesting that there's some systemic vasculature difference in these women who go on to develop vascular lesions in the placenta. And then Elise Hausberg, who did this work as a fellow and is now on faculty at Brown University, showed that vasculopathy, this most specific and chronic of the vascular lesions in a pregnancy without an adverse pregnancy outcome in a first pregnancy. So women can have these lesions, but have an clinically normal pregnancy. Their second pregnancy was about 2.5 times more likely to have an adverse pregnancy outcome. So women may carry an occult risk that is slowly emerging across the life course, if not in a first pregnancy, maybe in a second pregnancy as well. So that's some of our sort of population level work. And then, as I shared with you, we brought about 500 of these women back for a kind of a standard cardiovascular screening visit. And we also measured, we deployed this glycocheck device, which images the small vessels, the capillaries under the tongue, that then estimates vessel density, which is a marker of rarefaction, the vessel diameter, which is on average of those perfused vessels imaged, what is their size, and then sort of the proportion of them that are actually actively perfused with red blood cells. And what we found, even accounting for the adverse pregnancy outcome, the clinical outcomes, just the occurrence of these lesions were associated with modestly higher blood pressure. I mean, these are very modest differences. Surprised us a little bit that there was a more atherogenic profile as well associated with the occurrence of these lesions. And perhaps we were really on the hunt of this kind of, might there be a microvascular phenotype that is a little bit impaired and still detectable as soon as 10 years after pregnancy? And then Malamo Kantoris also led our echo study of these women. So about 150 of these women we also brought in for 2D echoes. And she found that those who had a hypertensive disorder of pregnancy and current hypertension, almost 80% of them had evidence of left wall remodeling, of right wall thickening. And then we also, under the guidance of Lisa Villanueva in cardiology, we did myocardial contrast echo to try to quantify the small vessel perfusion of the heart itself. We use these microbubbles that actually mimic all the kinetics of the red blood cells. We perfuse them, and then the ultrasound burst lights them up, and then we quantify how rapidly the small vessels of the heart can adequately reperfuse under stress. We were using a dobutamine stress. And then Malamo has just recently, just last year, published that women with hypertensive disorders of pregnancy were much more likely to have microvascular dysfunction, defined as a coronary flow reserve less than 2. Under stress, the heart ought to be able to double its perfusion, and that women with a hypertensive disorder of pregnancy were less able to mount that appropriate perfusion response to a stress. And about 32% of women who had hypertension in pregnancy had evidence of this microvascular dysfunction in the heart, and that was particularly detectable in those who also had already signs of right wall thickening. So hints that there might be sort of this might be a piece of the progression from the adverse pregnancy outcome that has, progression to chronic hypertension is part of it, and there appears to be microvascular dysfunction as well. Her work also showed that this microvascular dysfunction in the heart was related to BMI and hemoglobin A1C, but not to blood pressure, right? So there's probably multiple pathways, kind of the classic vascular pathways, and probably some metabolic pathways that are converging to damage the heart. And as I said, and I'll share some of those data with you, maybe maternal brain as well. And this is just a reminder, I think, of our expanding appreciation for the contribution of coronary microvascular dysfunction to a variety of cardiovascular diseases, some of which we know tend to be more common in women relative to men. So again, early days in these stories, but we've begun to really be quite interested in microvascular health and function and how to preserve it. And then we began to ask the question, where else does small vessel disease matter? And certainly brain as well. So we did a small pilot study in these same women who were part of our cohort of 500 women. And we brought 20 of them in for a very modest cerebrovascular reactivity challenge, which was a basic breath hold. So we put them in the MRI, we asked them to hold their breath, and what you expect needs to happen. Our brains are so tightly regulated for their perfusion response that even with a simple challenge like breath hold, the vessels respond, and there is increased perfusion that we can quantify on MRI. And this just shows you how. So you can see the image at the top is at normal breathing. The second row is under the stimulus of the breath hold, and then we can quantify it. That's what we've imaged here in the yellow. And then Beth Shaban has published this very small study to show that there's 3 groups that we studied in this very small pilot, those who had no vascular lesions in the placenta and no preeclampsia, that's the group at the top. Those who had preeclampsia without vascular lesions, which we are uniquely able to study by having evaluated the placenta, And those who we hypothesized would be the most adversely affected, those with preeclampsia and these vascular lesions. And you can see in all of these panels, the black line is perfusion at rest by region of brain. The red line is this expected increase in perfusion in response to the breath hold challenge. And in the women with preeclampsia and these vascular lesions, there appeared to be certain regions of the brain that were unable to mount that expected response. And that correlated with our cognition tests such that that same group, the group with preeclampsia and these vascular lesions, had lower scores, definitely not impairments, but just lower scores. And this was at about age 38 in executive function and processing speed, but not yet in memory. So that was preliminary data that led to our current grant, where we're bringing these same 500 women back. We're actually doing MRI imaging in 450 of them. Tough recruit because we're now using a CO2 challenge. But anyway, we're doing it. We've just hit our 300 mark of a 450 person study. So, go epidemiology, and hope to learn more about, like, this was a small study. Can we replicate it? And can we begin to understand early mechanisms and maybe even sort of lower touch screening? So we're redoing our glycocalyx evaluation. We're evaluating neuroinflammatory markers, right? So is there a way we could screen that high risk group before we have to image them in the MRIs? So hopefully we'll have those results within the next 2 years. And then Andrea Barra actually has taken this line of inquiry to study how is this impacted during the preeclampsia pregnancy. I'm sorry, these lines are a little bit hard to read, but the upper two panels show that women with preeclampsia self-report more memory problems in late pregnancy. Maybe there's some recovery post-delivery, but maybe not. She evaluated cognition late pregnancy, 1 month postpartum, and 3 months postpartum. We're studying women 10 and 15 years later, but she's studying them right at the time of the acute event. And then with objective assessments of cognition, these women with preeclampsia also have lower scores on processing speed tests, so consistent with what we saw at 10 years. She also is working with Bedoy Fan, a medical student, to look at, she's an anesthesiologist, so she's actually collected CSF as well. So she's looking at protein expression in the cerebral spinal fluid that might be related to both preeclampsia and some of these cognition differences, with the hypothesis that there may be a bit of acute injury at the blood-brain barrier. So much more to be learned, but that's the work that she's pursuing. And while we're talking about kind of being closer to the acute event of pregnancy, I would be remiss to not talk a little bit about maternal mortality and morbidity. We know now that levels of maternal morbidity and mortality are at sort of crisis levels in the United States, with really profound racial disparities. You can also see that, especially during COVID, these data here come through to 2020, rates continued to increase across all race strata, but increases were particularly profound again among Black mothers. And this is true for severe maternal morbidity as well. And we talked about this over dinner last night, that the maternal mortality disparity for Black women actually increases with education, such that the disparity is about 5-fold among college educated or more or higher Black compared to white women, and that Black women with a college degree die during pregnancy or the year after at rates higher than white women with less than a high school education. So that the socioeconomic sort of health benefit for Black women is not detectable in maternal mortality. And it turns out, as I learned last night, that that's true for other disease conditions as well. And when we look at causes of pregnancy-related deaths in the US, I've circled here in red the ones that are directly cardiovascular related. And then in the dashed red line are those that are cardiovascular risk factor related, so that are higher in those with, for example, pre-pregnancy obesity. And anywhere between 40 and 60% of maternal deaths are due to cardiovascular causes. And then these data came out recently from at the Centers for Disease Control that looked at data from 36 US states that do a much more in-depth maternal mortality review. I sit on one of those committees at our hospital. So we now actually understand a couple of really important things. First of all, that more than half of maternal deaths occur more than a week after a mom is delivered. So these deaths happened at home. Up to 1 year postpartum, and that the dominant causes for Black mothers are cardiac and coronary in nature, and the larger causes for white mothers are mental health related. So there are race differences both in the occurrence and also the etiology of maternal deaths. And I had this conversation earlier, I'm an epidemiologist, longitudinal studies, observational cohorts, are such a bread and butter of what we do. But probably 7 years ago, I began to think there's so much we don't know, but there's a few things we do know about the link between adverse pregnancy outcomes and the emergence of cardiovascular disease. And we know that blood pressure and weight retention contribute, blood pressure in particular. So we were fortunate enough to, through a philanthropic grant, which is this also a shout out as we think about how do we move forward. I can tell you that the most profound innovation that my group has been able to do almost always begins with some kind of institutional or philanthropic grant that then we can leverage into a larger study. So we had so many questions, would women even enroll in a lifestyle intervention after they just had a baby? We were told, no, Janet, that's not going to happen. You can't find them. You can't reach them. They're taking care of their babies. But we said, well, let's try. So we enrolled women with a hypertensive disorder of pregnancy in an intervention, and we randomized them to usual care, to those who had, we gave them devices to self-monitor their blood pressure only, and for a year, up to a year postpartum, and then a group that got self-monitoring devices paired with a remote health coach. So we were it was really a feasibility study. We also, understanding that there's so much we don't know about maternal health after delivery, and particularly the burden among Black women in our community. We also very intentionally partnered with Healthy Start, a community-based agency serving Black mothers in our region. We were going to do community events. Our pilot trial was about a third of the way underway when COVID hit. We pivoted to remote, which I have to say, we learned a lot. Turns out postpartum women really prefer remote study visits. Surprise, surprise. And we could do them. And all of our community education then became like Facebook Live, social media interventions. We commissioned a video, which I don't have time to show you. But we did a lot of community partnered education because we thought we need to build those partnerships, and we need to learn how to do that. And then Elise Hausberg published our findings of this small study. Yes, we were able to enroll women. About 30% of them were Black. They were very adherent to our self-monitoring protocol. We asked them to measure their blood pressure remotely with a home device for 7 days every month. And they measured on average about 9 blood pressures per month across our trial. And we had almost 90% retention through 1 year postpartum. And we were not powered to look at blood pressure differences. I've shown you the differences here in mean arterial pressure. But interesting to us, this 3 millimeter mercury differences about mirrors what we see in trials among those with outside of pregnancy sort of hypertension management trials. So we were a little bit encouraged. Women would do it. We learned a lot about how to work with moms. Again, because we were in COVID, we couldn't do a blood draw, but we actually tested this self-blood collection, this sort of blood spot collection. And now Elise is working with a team to look at protein expression in those who do and do not progress to hypertension by 1 year postpartum in this trial. So just an example of how we can take adversity and turn it into new opportunities. We are in a different time now. But again, I think as we pivot and learn how to continue to the work we do, there are ways we can succeed. And now, as a result of that small pilot, we now have the really good fortune to be one of 6 sites in a big NHLBI lifestyle trial, which by design pairs a cardiovascular health intervention with evidence-based home visiting, which in the pediatric world is well established, funded by HHS to serve high-risk families to improve child health and development and parenting. And we are testing whether or not the incorporation of a cardiovascular health intervention can improve cardiovascular health in mom as well as her child. So we're enrolling in pregnancy. We've just started. We're about 10% of the 3,000 women and the 3,000 dyads are now being enrolled across 6 sites, and they'll be followed for 2 years. So that trial is underway. And we are also we are about a third of the way through a single site trial with my colleague Isa Davis, funded by NIMHD, where we're specifically looking at Black-white differences in blood pressure patterns after a hypertensive disorder of pregnancy. We are randomizing to usual care, which at our hospital is 6 weeks of remote blood pressure monitoring. But what if we continue self-monitoring for a year, as we did in our small pilot, and actually in partnership with our community partner, Healthy Start, they've built out what we fondly call a heart health postpartum doula. So it's a doula paired with a mom to do one-on-one teaching in the first 8 weeks postpartum, and then peer support after that. I didn't even know postpartum doulas were a thing. And so I learned as much from my community partners as I hope we might be sharing with them. So we are leveraging this sort of their expertise in postpartum doulas, and we have these devices that we're fond of as well, home blood pressure monitoring, scales, and a Fitbit. And then we have developed these heart health coaching modules. We've trained the paraprofessional postpartum doulas to deliver this intervention, and we'll follow these moms through 1 year post-delivery to look for blood pressure improvements, and importantly, by design, to be sure that if we are making an impact, and is that impact equitable between white and Black mothers? In our community, we have very small Latino community, so not enough to study that group. We have hopes of expanding to a Latino community, but we'll have to see what the future holds. And then the last piece I want to share with you is our beginning thinking of preconception health. And these are work we did in the cardia cohort, where we looked at preconception cardiovascular contributors to the occurrence of severe maternal morbidity in Black and white mothers. And what we found is that Black women with severe maternal morbidity events, this is things like hysterectomy, heart attack, stroke, death. So among Black mothers, their preconception cardiovascular health, about 40% of them using the AHA Life's Essential 8 were scored in the poor cardiovascular health. That was almost undetectable in white mothers with severe maternal morbidity events. And then we also looked at the number of preconception life stressors, and there was a hint that Black mothers with severe maternal morbidity events were also reported more pre-pregnancy life stressors, leading us to sort of have this appreciation that, particularly among Black mothers, the contribution of poor cardiovascular health pre-pregnancy and the accrual of stressors likely is contributing to kind of the worst maternal outcomes that a mom can experience in pregnancy. And then we've just begun to think about this notion of, in pediatrics, any of you who work with folks in pediatrics, there's this notion of the first 1,000 days of life in pediatrics is super important to sort of establish lifelong health. But this commentary from a couple of years ago said, what about mothers. Like if we're not thinking about putting mothers at the center of this, then we're never going to make an improvement in infant health. So our group began to think about what about the concept, and this is like early days, aspirational. I don't know how to do it, but this is where our thinking is. What about this concept of 1,000 days of maternal health, which is the year before pregnancy, the 9 months of pregnancy, and the 12 months after delivery? That turns out serendipitously to be about 1,000 days. And that, I don't know how to do it, but my thinking is that if we can actually improve women's health across these 1,000 days, we will likely have better pregnancy outcomes and perhaps better lifelong health for mothers as well. So, and to get started, again, we partnered with our friends at Healthy Start. We've developed community education modules, and they hosted a community heart health event last year that launched these pieces. We're thinking about, could we do a step challenge? Other ideas, or could we talk about grandmothers and mothers? Is that a way to think about improved health before pregnancy? You all may have ideas. Like I said, I don't know how to do it, but I actually don't think we're going to make much impact until we begin to improve women's health even before pregnancy. So that's where I'll end it. I always like to have a shout out to some of our youngest supporters at our hospital, and the amazing team I get to work with, and my collaborators across disciplines. I wouldn't be able to do this work without amazing colleagues in cardiology, in neuroscience, psychology, public health, of course, and in the community, and of course our funders. And that's what I've got.
Questions in the room, and then we'll also monitor online.
So, so you started talking about this concept of vasculopathy.
Yes.
The underlying pathology for the APOs as well as for cardiovascular. Then towards the end of your talk, it really emerged the importance of actually cardiovascular risk factors, even pre-med.
That's right.
Cardiovascular health among women. So, how much do you think that actually vasculopathy, those abnormalities are actually due to traditional cardiovascular risk factors versus something else that may contribute? Could you maybe speculate? I don't know if you really have the answer, but
we've certainly thought about it, and it's a great question. We get a comment both from grant reviewers and paper reviewers. Well, just tell us what causes the vasculopathy, and then we'll have the answer. But we just don't know. I suspect, we don't have the data. Like what I would need, right, is a cardiovascular assessment pre-pregnancy, placental data during pregnancy, and then the follow-on. But we don't have that yet, but I'm hoping we will. I suspect that a portion of the cardiovascular risk factors are definitely contributing. We know that women with pre-pregnancy obesity or chronic hypertension, higher risk for vasculopathy. But it likely doesn't explain all of it. There is probably some idiopathic, occult difference. So, I talked about this tiny little study with intriguing data about an early impaired vascular response to pregnancy. So why is that, right? And those are really, none of those blood pressures were in even a stage 1 hypertension, right? So there are subtle differences in blood pressure. We can see it, but it's not discriminating enough to predict. So I don't know the answer. My hunches, you asked me to speculate, is that the pre-pregnancy cardiovascular risk is contributing to some, and maybe a lot. I don't know how much, but definitely some. We've begun to think if we deeply study these women post-pregnancy, we might begin to disentangle that, right? So pre-pregnancy would be ideal, but could we begin to discriminate those groups post-pregnancy. That's why I think some of the protein expression work, I think, will be valuable. There is also, there's now one of my colleagues at McGee has, he's like a liquid biopsy kind of person, right? Looking at now we can get a blood draw in early pregnancy. We can identify fetal, placental, and maternal material. And could we use that to identify sort of who in that early pregnancy are already showing a high-risk profile towards the placental poor placentation and the APO? Because in the OB world, it's been about predicting who's going to get these complications. And just the cardiovascular profile isn't quite enough. So I suspect it's a combination, but we've definitely remained keen on that. We won't know how to find that unless we can disentangle like, for example, the preeclampsia with placental damage and that without. And I can tell you for preeclampsia, whether or not they have those vascular lesions, they progress to hypertension. But maybe there's an additional insult that's microvascular in nature. That's kind of a second hit. But that's still a hypothesis.
We need a big cohort to look at.
Always our answer. We need a bigger prospective cohort, but you're right. You're right.
Thank you. Fantastic talk. And kind of building on that question, I was curious about one of the trials you presented where you emphasized that the intervention is a cardiovascular health intervention. Mm-hmm. So which aspects of the essential 8 are you targeting?
Yeah, so in the large multi-site trial, our endpoints are the four sort of cardiovascular health factors. So BMI, cholesterol, A1C, and blood pressure. The interventions are focused on physical activity, not sleep, because there wasn't enough evidence about how to improve sleep in pregnancy. And there is this, even though there's like no good data on any of these, there are at least some data about, from the GDM world about weight gain in pregnancy and weight retention. And probably the most convincing data around preventing lifestyle intervention to prevent adverse pregnancy outcomes and improve cardiovascular health is physical activity. It might also be sleep. We just don't have those data yet. Maybe that data will come. But it's focused on those. It's really focused on healthy diet, physical activity. There's some stress reduction. Our doula trial has a big emphasis on stress reduction. Mostly because that's what our pilot showed us. About 28% of the women in our pilot by 1 year postpartum reported PTSD symptoms. So we know there's a traumatic stress-related piece of this story. But that's what we're focusing on.
Hi, my name is Ariana. I'm an MD PhD student here, and my focus is very much this like pre-pregnancy period. So I think it's really great to have that emphasized. And so I was curious kind of what the response has been so far. Like, are you getting buy-in for this idea of, 1,000 days of maternal health? I like my own research is kind of around the fact that we just don't have data for the pre-pregnancy period. So like, how can we try and like impute around that?
Yeah. Are you going to figure that out? That would be great. That would be great.
But yeah, so I was just curious, particularly, I mean, like, you've kind of been talking around like this changing landscape around funding. And really pre-pregnancy health is getting at universal health, and that just doesn't have that kind of support. So I was just wondering kind of what the response has been around that.
People like it. And there's been a couple failed efforts. Like, I was part of an expert panel at NHLBI that was keen on this. We're going to do it. We're going to do a trial. And what they really proposed was a pharmaceutical intervention pre-pregnancy to improve pregnancy health. And then they sort of didn't anticipate the fact that all of these medicines are really things you're not supposed to take during pregnancy. So that actually, we met for 2.5 days. And it became, oh my gosh, we don't know how to do it, right? But there was interest. They convened a group. So I think there's appetite, but we need to build the expertise that begins to hint at how to do it. Like even this lifestyle trial we're doing during and after pregnancy, you know, they wrote the RFA to be evidence-based, and there's just not enough evidence, but there was enough evidence. But I'll tell you that what took that trial from a good idea over 10 years ago to actually now in the field was a lot of dedication from a team of people at NHLBI and expanded awareness and NIH funding around maternal morbidity and mortality from multiple institutes. That project would not have happened had there not been cross NIH in sort of awareness and enthusiasm to invest something in improving maternal health. So it's like we have to keep working for the next amazing opportunity. That's the best I got. And I feel like, you know, I'm happy to hear you're interested in that. You know, people like the idea, and I keep talking about it. In fact, I'm writing the paper now with the president of the Society of Maternal Fetal Medicine, right? She's like, this is what we should be doing, right? So, you know, it's just one idea, and we just don't know which idea is going to be a good idea, you know, moving forward. Maybe you'll come up with the good idea. I would love that.
Naive question, maybe building on the idea of the preconception health. What is the impact of pregnancy, broadly speaking, on the whole cardiovascular life course? Is it generally positive, negative, neutral?
Great question. Not naive. You know, I think it's a bit of a mixed story. If we look at uncomplicated pregnancy, and actually we know this from Cardia, and maybe from some of the Scandinavian cohorts, that uncomplicated pregnancies, around 2 or 3 uncomplicated pregnancies, leave the vasculature a little healthier. So blood pressure will be about 2 millimeters of mercury lower pre-pregnancy to post-first pregnancy. But HDL cholesterol never quite comes back, goes down during a first pregnancy and doesn't quite come back. My read on this is that there's a metabolic hit and a bit of a vascular benefit. So what's the net result of that? We also know that childbearing itself is just highly susceptible to weight gain. So this we know is an important piece. We've published work out of the new mom cohort. So again, looking at first births, and we looked at sort of an atherogenic, what we called an atherogenic profile in the first trimester. And was it related to the emergence of something like hypertension 2 to 7 years later? And it was, and it wasn't all traveling through adverse pregnancy outcomes. So I actually think there's even an opportunity to do some early life screening for cardiovascular risk, even in healthy pregnancies. But that again would be changing our notion of obstetrics. We're not just like, I had an obstetrician tell me way back in the beginning, you know, Janet, we care about things that kill moms and babies. Otherwise, whatever. But I think now there's this understanding that we might also care a little bit about women's health, and that preserving cardiovascular health across the reproductive years might also be important. I think that's another opportunity.
That could be our last note. Thank you so much.